is Shannon Potter. She's the manager of the Wound Ostomy Clinic, and she's going to be presenting today. The first half, the first hour, will be all wounds. And she's open to questions, and she's got a lot of stuff to play with to show you. That'll be for PTs and RNs, and then the second half will be on ostomies and wraps, low extremity wraps, and that'll be just the nurses. So feel free to interact with her.
All right, I've probably talked to you all on the phone. I'm Shannon. I am the wound ostomy manager, but I like to be a nurse better. I love taking care of our wound and ostomy patients. So this morning, I'm just going to start out with our inpatient wound ostomy skin guideline. You guys can adopt it and actually use this out in the field. If you see a patient and you have a surprise wound, you can refer to this guideline. And I think one of the nurses, I keep forgetting her name, Carrie, made you guys also a guideline. So whatever.
Diana Friedendahl.
Yes.
Yes.
So
it will be. Yes.
So whatever you guys want to use out in the field. But anyway, just remember that this is inpatient policy, so our wound providers go into the hospital and see patients when consults are placed. This is for primary nursing, like on the weekends or nights or even during the daytime when they get a patient with a wound and they just need a quick guideline on how to treat them. We do expect nursing staff to be able to treat stage 1 and 2s all on their own, and this guideline kind of tells them what to do. But anyway, so moisture-associated skin damage, we use, let's see, did you put it up here for me, mister? Right here. All right, so this is what nurses and CNAs follow for patients with moisture-associated skin damage from either urinary incontinence or any sort of incontinence. I don't think anybody personally knows me, but I'm kind of corny and I have to make up things to help me remember what to do. So the two skin products that you guys probably see are these ones, the clear zinc and then the more of the cream. They're both number 3s, so nursing staff gets confused on when to use which 3. The little tube is for littler skin problems. This is actually for people that are at risk for skin breakdown. It's not open, but it's definitely irritated from the incontinence. So that's when you use the small tube. It's for littler problems. The bigger tube is for bigger issues, and this tube is meant for actual wounds. So if you have open, weeping, denuded skin, you would use the cream. And it actually has kind of a granular texture, and it has like alginate in it, so it wicks away the moisture. You don't actually have to scrub all this off. Some family members, some nursing staff think they have to scrub this all off with incontinence, but you just wipe off the top layer and just add more if you need more. We don't want to cake it on. And then Triad is kind of a newer product that we started to use, and it's actually not on our guideline, but we use it for I guess, big, huge issues. So if they come to us and their butt is just hot, red, totally denuded, weeping, we would try the Triad, and that actually dries to be kind of like a hydrocolloid or a thin duoderm type of dressing. It's actually meant for venous, arterial, all sorts of wounds, so you won't just see it on the bottom. Sometimes we order it for lower extremity wounds. And you actually put this on the wound, and then it's directed that you use like an ABD pad or something to absorb the drainage that drains from it. All right. I didn't bring the lotions. I figured you guys would know lotions and creams. We do have the a cream over here. Oh no, where is our lotions? No, we don't have lotions on here.
Yeah, they're on the top.
Are they?
In the middle, the third one.
Okay, so we use, oh, there we go. We use the tube that actually looks like this for like diabetic flaky skin, and then just the round tube for normal skin. All right. So for yeast or fungal, we actually, we can't order the nystatin powder or the nystatin ointment, we would have a doctor or a hospitalist put that order in. But we do have stockinette, which we put in folds, and that is just kind of like a cottony material that helps wick away moisture. We also have this stuff called Interdry, and we do use this quite a bit for more of kind of like the denuded weeping skin. It has silver in it, and you are not supposed to use any lotions or potions or powders with this because it deactivates the silver. And you can use this up to a week as long as it's not nasty. So. And then skin tears. Skin tear practice has changed a little bit.
Shannon.
Yes.
Yes. Can they wash the Interdry?
They can wash it, but it washes away the silver.
Okay.
So we do have patients, it is quite expensive for a box of it if the patients purchase it. You know, and they want to keep using it because it is a good material, but it won't have the silver left in it.
Okay.
Yeah.
I understand that it does have the wicking power though still, so that you can
Yep.
use it to prevent things from coming
Yep.
back.
Yep, that is correct. And in the home, we kind of see a lot of the same patients, right? And we know they don't have a lot of income. And in the guideline you guys got from your nurse, it is an evidence-based practice to use a pillowcase or a t-shirt, but we tell patients you can use pillowcases or a cut-up cotton t-shirt to help wick moisture away. So if you hear that or get an order from us, we do say that just to, you know, some patients don't have money. I guess the materials come from you guys, but if you have patients that say, oh, well, my nurse told me I could use a pillowcase, we do say that.
But it doesn't have to be cotton?
It doesn't really have to.
Oh, it doesn't?
Well,
You think it
we
would?
would say cotton t-shirt, a white
Yeah, I'd
cotton
say like
t-shirt.
flannel, the cotton flannel sheets.
Yeah, I mean, anything that helps wick moisture away or keep it dry, I think is fine. Skin tears. I got sidetracked. So skin tears, we used to say reapproximate the flap, put steri strips down, but that's no longer the practice for skin tears. So you definitely do want to reapproximate the skin flap, that you can use a Mepilex border dressing, and I didn't bring a 4x4. You can use a Mepilex dressing, and our trick is we put it on and we draw the arrow in which way the flap is going, so the next nurse or provider knows which way to take the dressing off, so you're not re-ripping that flap of skin up. For little old grandmas and grandpas with the fragile skin, we just use like a Vaseline gauze or a Xeriform gauze, and just put gauze on top and use a surgical netting or secure it on with acrylics or cotton roll. And that's to be changed every day. ER and some of the nurses and some doctors out in the community still use Telfa on skin tears. We actually don't use Telfa on anything except for occasional burns. Telfa actually does stick when the drainage dries on it, and then us nurses have to go in and literally rip that Telfa off. Same thing with Tegaderm. It used to be that you could use Tegaderm over little skin tears. I don't ever do that because then us wound nurses or you guys have to go in the home and we have to rip it off again. So use a Mepilex dressing. For fragile skin, it's the Vaseline gauze. Stage 1 pressure injury, and I'll go over the stages with you guys in just a little bit. But stage 1, the nurse would just definitely start offloading wherever that injury is. The heel you would want to elevate with the pillow, or if they have a heel lift boot, you'd use that. And that's all we pretty much say for stage 1. Stage 2s, us wound care nurses, I said, are corny. When perplexed, Mepilex, you can pretty much Mepilex anything until you get an order or direction from a provider. So stage 2s, depending on where it's at, you can Mepilex it, or you could cream it up. So your choice, that both are on here. On the bottoms, we would cream it up pretty much. Anywhere else, we would Mepilex it. If the cream's not doing its job, then we would Mepilex it on a follow-up visit. Stage 3s or 4s, wet to dry dressings are pretty much old school, but they still serve a purpose. We at the wound clinic still use wet to dry dressings if patients come in with disgusting necrotic wounds, and it's really just for the cleanup phase. And our policy in the hospital is if you get a stage 3 or 4 on the unit and you don't have your wound care nurse here and you don't have the providers, it is okay to use what we call a damp to dry dressing until you get an order for otherwise. Unstageable pressure injuries, you just leave it open if it's not draining, because unstageable means it's just all full of necrotic tissue. So you can leave it open or cover it with the Mepilex until otherwise. And then deep tissue injuries are just that purple maroon discoloration. It shouldn't be draining yet, and you can leave those open too. But the standard of care, of course, we're turning Q2, you can always put them on an air mattress. That's it for our skin guide. Do you guys have any questions? I know somebody asked on our guideline, we have it to change Mepilex dressings every 3 days, and that is because we want that wound assessed. We want to know that the nursing staff has taken the dressing off and assessing that wound. And when patients are in the hospital, most of the time wounds are nasty and need to be changed anyway every 3 days. But Mepilex are actually meant to stay in place for up to a week. So I'll let you guys decide. Of course, you'd use your judgment. If the wound edges are macerated, you would want to probably change it more often. But if it's like a skin tear and it's not weeping very much, I would leave that dressing on up for the whole week, just so we're not irritating that flap. Any questions on the guideline? Yes.
Another question. I wish I could remember the name of the stuff. I think it's called pomegranate.
Pomegranate or Prisma?
I've never really seen that before. Like when would I recommend like using that on a wound?
So if you have a wound, and this is it, it looks like we call it.
Yeah. I've never seen it before, and I was like, oh.
Yeah. So it is a collagen, and the Prisma is actually that. The Prisma has silver in it, so it acts as an antimicrobial, and then the pomegranate is without silver.
Okay.
And you would use this if you have a wound with a little bit of depth and it needs to be clean. It needs to have a clean wound base so it can actually do its job. The pomegranate or Prisma will melt into the wounds, and it just promotes tissue growth.
Okay.
Yep. If you have a lower draining wound, you want to dampen it with just like even just tap water a little bit. Just put a couple drops on there, damp it, and then put it in the wound. If the wound's not draining, then it's not going to dissolve and do its job. So just a lot of times we use it on trauma wounds or lower extremity wounds with just a little bit of depth, or even a lot of depth, but it needs to be clean. And that is supposed to be changed every 3 days. Yes.
So I'm just a PT, so this isn't my big realm, but just like a stage 2, first of all, you said no Mepilex on bottom, you start with the barrier cream first?
Yeah, if we go in, if we have a stage 2 on a bottom on a coccyx, or in between the gluteal folds or something, kind of where it's going to be moist all the time, we go with a barrier cream.
The
Just
big, is that
yeah,
one
the
has
big
zinc
problem.
in it? Does that one have, is
Yes.
that difference in those two?
Yes.
Yeah.
They both have zinc. This is a clear zinc, but this is a cream, and it has like the granular like alginate in it to wick away moisture.
I wish we had standing orders that we could use those, because we have to actually get orders to use those.
Yeah, that's
It's in our
my
policy.
question.
That's what I
Yeah,
thought, it
that
was
was
in
my
our
second
policy,
question.
but it was
Every
every,
hospital policy.
but we're hospital, I know.
That's my
Yeah, 'cause
question with
typically,
all
like,
of
we have to
this.
call.
Yeah.
Can we do all of this without a doctor's order? or
We
no?
do.
So maybe that needs to be
Yeah, so I think we
because
need to get that
usually
changed,
can't.
because to me, that's just, you know, I have patients that say, well, I've been using Desitin, because it's almost the same kind of thing. And so it's like, but we have to get an order for that, which to me, we shouldn't have to get an order because that's standard practice and it's in our guidelines.
And sometimes it takes to get an order back from a doctor.
Especially VA doctors, it takes forever.
Yeah. So I don't really know the regulations and rules with home health, but it is our policy, and nurses do this without
All the
orders
time.
all the time.
I'll work on that.
Yeah, at
Yeah.
the hospital, they do it all the time. They
Yeah.
don't have to have an order, they can just bring that thing in.
Yep,
I will check on that.
so, yeah. The only thing that we do need the order for is the NISTAT.
Yeah. Nice to have.
Yep, and then if somebody, I'm glad you brought up the Desitin, because there are patients that come to our clinic and they prefer to use their own barrier cream, like the Desitin or what, butt balm or whatever.
Because you can get the Desitin clear and the Desitin
Yeah.
thin and the Desitin thick and, you
Yeah,
know, it's almost the same concept.
yes, yes. So that's okay with us. Any more questions about the guideline? Remember, these are just recommendations. Not every wound is gonna be treated specifically like this, but at least gives you a guideline on how to treat most wounds. And if you have questions, just call and ask,
I'll do that.
or refer them to the wound center. Okay, this is just our inpatient hip pressure injury prevention algorithm. It might be useful in the home just to kind of tell you when to get cushions and airbeds and all that good stuff. Oh, let's see if I remember how to do this. File.
Go up to
View.
view, yeah.
Let's see, here we go. And if I say something funky, correct me, because I have been sick and I've started medication that might make me a little tired, so just let me know. Pressure injuries can be tricky, but I try to make it as simple as possible. So stage 1s are non-blanchable redness. There's no wounds. It's just non-blanchable redness. Stage 2 is a shallow wound. It's like a blister that just that top layer of skin is missing. There should be no slough or dead tissue in stage 2s. It's just going to be a pretty partial thickness pink wound or a serous-filled blister. I skipped stage 3 because stage 3 it gets a little mucky. I go straight to stage 4, and if I see muscle, bone, tendon, I know it's stage 4. Everything in between is a stage 3. Stage 3 is just into subcutaneous tissue. You can have undermining and tunneling. You can with stage 4 too. Unstageable pressure injuries are wounds that have necrotic tissue. Hold on. Necrotic tissue in them, and you can't actually see the wound base. You don't know if there's a tendon or a bone underneath that tissue. So we call it unstageable until it's debrided or until it's cleaned up. Once we see the base, then we can stage it. Deep tissue injury, we see this quite a bit in the hospital. It is just a purple or maroonish injury. And most of the time, there shouldn't be any drainage. It will start to blister and come off, and then that's when we can stage. When it declares itself, then we stage
So if you
it.
have a huge bruise, you know, I know I've fallen before and gotten a big bruise like that, is that considered a deep, no? it's
No.
not. Okay,
That's a hematoma.
okay,
How do you know the difference?
yeah.
From a
Well,
PT?
sometimes it's really tricky, but if it's over a bony prominence, or if they were laying on a cord,
That's a deep
Yeah.
tissue.
And does
Yeah.
that eventually open into like a stage?
yes.
where
So.
you're over?
And sometimes this recently just happened, we had a patient come in, he was super duper sick, and they were calling it, it was kind of on the buttock, kind of weird, not really over a bony prominence, and they were calling it just a retroperitoneal bleed. Because his platelets were low and he was just kind of bleeding everywhere, but we monitored it and it did start to blister and open up and became a huge pressure injury. So you really just have to see what it evolves to. Yeah, so a true deep tissue injury will most likely evolve to a stage 3 or 4.
So a deep tissue injury is not caused by trauma, like a hematoma would be?
No.
Like it's the etiology, that's the difference?
Yeah, most of the time hematomas are called from, from some sort of trauma. We see them all the time, a little old lady bumped her shin on her dishwasher or something, or, you know, just any sort of trauma. A car door hitting them, it bleeds underneath. Yeah, and sometimes it does get tricky, so you just have to monitor it, and if it starts acting like a pressure injury, then it probably is a pressure
But
injury.
would you wouldn't call it a deep pressure if you don't really, would you call it that?
What we chart is a wound from it's unknown if it's pressure or from a bleed.
Potential.
Yes,
Pressure
potential,
injury,
so
okay.
we just say we keep monitoring, and if it truly is a pressure injury, it will start to blister and open up and be deep. Yeah, hematomas can be deep too, but if it's over a bony prominence, it's probably pressure. Most of the deep tissue injuries that we see in the hospital are patients laying on a wrinkle and it's a straight line, so it's linear, so we know that's a pressure injury. But most pressure injuries start over bony prominences. Mucosal, we won't go over that. But any questions on stages? I think that's it from our guideline. This is all in our guideline, GNC 1620, if you guys want to really look at it. We'll go over dressings. All right, and I think you guys got this one too. Did you guys get this in your email?
Yep.
Okay. So alginate dressings we don't use in the wound care center. Alginate is just a dressing that absorbs drainage. We choose to use Aquacel, which is a super absorber. It absorbs 30% times its weight in drainage. It kind of turns like a jelly worm, a gummy worm.
I had a guy that had the
Promogran.
and that on top.
Yes, so
Okay.
if the wound is highly to moderately draining and our provider wants to use
Okay.
a collagen dressing, you can put the collagen in, Aquacel over it, and then most of the time we would cover it with a foam or an ABD pad. It is expensive, so we don't really use it on wounds that need to be changed daily. Anyway, that's Aquacel, and we use that for highly draining wounds. Prisma or chromogram, we discussed that already. It is just a collagen, and we just call it wounds food. It's supposed to promote tissue growth, but wounds need to be clean. Sometimes we got to remind our providers that. Composite, or I don't know why I'm going by this. I'll just go by my dressings. Not Aquacel, ABD pad and Exudry. You guys have all seen those, right? We do use those for a lot of lower extremity wounds that are weeping quite a bit that do need daily dressing changes.
Are those considered island dressings?
No, I'm not going to go by that anymore. Because there are some dressings listed on there that we don't use. We don't really use island dressings. So, but anyway, any questions? The soft sorb absorbs drainage. It wicks it up into the dressing. ABD pads just kind of let the moisture sit on your leg and can cause maceration or more irritation. Duoderm, we do use thin and thick Duoderm on certain wounds. Sometimes we use them under ostomies. Sometimes little grandmas and grandpas just like it on their coccyx to prevent the friction and shearing of wounds. We do use it. You might get a wound vac order that says use Duoderm around the peri wound, and sometimes we do that, but we place it kind of like on the granulation tissue so the wound vac isn't sucking on it, so it can epithelialize, so it can start healing in. It does turn kind of white and ooey gooey and can cause maceration, but there are purposes for it. Xeroform Vaseline gauze or Adaptic. We use, you'll see the Xeroform over surgical sites a lot of the times from orthopedics most of the time. Our providers are kind of on a Xeroform kick right now. We kind of go in waves of what products we really love at the moment. But they are using it on lower extremity wounds that tend to drain a lot just to prevent the dressings from sticking. So you might see us use it Xeroform over wounds and then wrapped with the ABD pad. Adaptic, we sometimes use in wound bases of wound vacs, and that is just to prevent the sticking of the foam. And also some tendons and bones do not like to dry out. If they dry out, they die and need to be degraded out. So it is the protocol from KCI, the company that we use for our wound vacs, to cover those structures with Adaptic or Mepitil. You all know the packing, the iodoform packing. Iodine, we use iodine a lot. For our diabetics and our lower extremity patients that we don't know what their blood flow is, there's another wound care saying, if it's dry, let it lie. We don't want to be debriding off a big chunk of eschar off the heel of a diabetic patient because we don't know their blood flow. If you debride that off and they have bad blood flow, that tissue is just going to keep dying and going to keep being debrided because of that dead tissue, and it just ends badly most of the time. Most of those patients have to go in for amputations. So if it's dry, let it lie on the feet and some lower extremity wounds. And that's when you'll see our order for paint with betadine daily or keep it dry with betadine and dry gauze. Mepilex we use a lot. You can use these on moderate to highly draining wounds. This is silicone. So most patients, if they have a tape sensitivity, they will not be sensitive to the Mepilex. We occasionally do have silver Mepilex, but not often. You've seen the sacral and the heel dressings. And then we have non-bordered Mepilex, and this is primarily used if patients come in and they're too moist. Their wounds macerated around the wound edges. We'll go to the non-bordered and either secure it on with a roll or you can just tape it on, but it allows more airflow. If you have patients that complain of pain with any sort of tackiness, because this one is supposed to be so gentle on you, but some patients can't even tolerate this, you can put it on upside down. So you can put it non-sticky side up. Just make sure you're taking the backing off. And we do have some patients we have to do that too. We talked about stockinette and intradry. Some patients, if they come in with a little bit of edema or a lot of edema, sometimes we put them in tuba grip, which just has like 10 to 15 compression to it, just like not a tight compression sock, but just enough compression for the little people that have swollen legs that do not tolerate our compression wraps. Some patients wear this for the rest of their life once we get them healed, just because it is easier to get on than a compression sock over the heel. We do use ACE wrap. We don't use it on big honking swollen legs. If you do it, we've just seen it pinch, where it's wrapped, it just kind of pinches the skin and causes bigger issues. We do use ACE wrap, but not often. We'd rather use the tuba grip. Any questions, or did I miss a dressing?
I have a patient of your guys right now I'm using Hydrofera Blue on.
Oh, so
Yeah, what? It's like antimicrobial?
it's antimicrobial, it's kind of moist. And that's another, our provider will get on a kick of trying something new.
Okay.
We don't carry Hydrofera Blue in our clinic. This is all the products we carry, pretty much. I don't really know how is he medicated? I don't know how he's getting Hydrofera Blue.
She said she got it from you guys, from
It was probably a sample.
Jill.
Yep, it's probably a sample. She goes to, conferences and
Okay.
comes back with samples and
Okay.
wants to try them on patients.
Well,
But no, we don't carry that.
okay.
Yeah, but we have ordered it a few times for patients
Okay.
through Prism or wherever else. Yep. And one of the things I didn't go over, we kind of go in kicks with this too. This is just a wound manager. It isn't an ostomy appliance. Sometimes we use them on ostomies, but it is just for a highly draining wound that you can put on. A lot of paracentesis sites will just drain and drain and drain, and you can throw one of these bad boys on and makes your life much easier instead of having to change a dressing 10 times a day.
Do you have to cut that, or?
Yeah,
Okay.
you would still have to
Okay.
cut it to fit the wound, or with a little needle site sometimes that we see, just cut it a little bit, put it on there, yeah. All right, anything else? Did I miss
was just
anything?
curious, with that bag, is that attached to a tubing in case?
It can.
Yeah,
Mhm.
okay.
Yep, you can hook it up to a Foley bag. Yep. Did I miss anything? I felt like I went faster this time around with the dressings.
Can you,
I'm on medication,
Can
I'm
you talk
on
about,
medication.
the calamine Coflex a
Mhm.
little bit?
Yeah, and I
We've been
do,
using that, I have a patient that, we're just using it to prevent edema, you know, and they've been doing it for probably, I don't know how many years it's been on service, but the VA's been paying for it
Wow.
every week we book.
wow. So we do have a few chronic patients, venous patients that we will wrap with calamine, get them healed, and they're supposed to use compression stockings for the rest of their life. And then they forget one day or quit taking their Lasix because they don't want to go pee all day. And then they balloon up and get more blisters. So some patients, these venous patients that are kind of non-compliant, we see them for the rest of their lives because we'll heal them, and then a month or two later, they'll come back and confess what they did wrong, and we have to start over. Some of the patients are a week on a wrap, a week on compression stocking or Juxtalite, come into our clinic, you know. Yeah, and some patients prefer to be wrapped so they don't have to fuss with their Juxtalite or compression wraps, which seems crazy to me, but some of them.
So, the guy that I see that has that, he always gets these, he bumps his, because he doesn't wear shoes, so he bumps his toes, and then he gets these little sores on his toes, but I don't think you should put, that would be one you'd put the betadine on, I think, just to keep it dry,
Yeah,
because you wouldn't really want to do anything with those toes.
yeah. Sometimes we just put dry gauze on them, or
Yeah,
tell them you need to wear at least cotton thick socks
yeah.
so you don't keep bumping and banging your feet. But I did bring a box, but I do need a leg model if somebody wants
Is
to
the
offer me
Calamine,
their
is that
leg.
what they call the Una boot, or is that different?
That's different.
Okay.
So Una boots are kind of old school, and I did get a question from somebody about a Una boot yesterday, I think, but Una boots are kind of out, but some providers still use them. We don't use them. I can't remember, maybe 10 years ago I used one.
Oh, I've seen them more recently.
Oh, really? So we do have the calamine, and then we do have the zinc
Okay.
Coflex, and sometimes providers call them Una boots because it's zinc,
That might be.
but it's not truly a Una boot.
Okay,
If it's coming from us, it's not a Una boot.
gotcha.
Some podiatrists probably still use it. But
So toast your nose, girly.
Toes to
okay,
your nose.
toast your nose. We want the ankle kind of bent. Toast your nose.
Oh, sorry.
There you go. Kind of, you know, a 90-degree angle, just because when they walk, you don't want to have it bunch up, you know, in the front. Have blisters, you see that. All right, and we need to start at the base of the toes and wrap like this, not this. This way you get wrinkles and it just moves funny. This way you can keep it in control and tight. It is hard to wrap like this.
Can we put it on the ground?
No. All right, so if you read, do you guys read the inserts before you put on one of these?
Yeah.
Okay, so the directions say, even with this calamine foam, to do a figure 8 around the ankle. Some nurses do, some nurses don't. I'm one of the nurses that do not do that.
I don't need them.
Because patients don't like a big thick dressing on. I do a figure 8 with the Coban, but
Can
not,
it stay on better with a figure 8?
They won't be
Not
able to put their shoes
necessarily.
on.
Yeah.
all right, so we'll just, oops, missed your heel. Ooh, it is hard to wrap like this. This looks ugly. There we go. That's better, thank you.
Here.
Calamine is cool and soothing, that's why we use it. Some people ask us why we put it directly on a wound. Well, sometimes that wound needs to be soothed. And sometimes it has, some slough in it, and the foam kind of like dries and kind of helps clean it when we take it off.
It's cold.
It is cold.
It's 18 degrees
You
outside.
used to put on when you got chicken pox.
Yes.
Calamine.
Yes.
Oh, I remember that, yeah. We didn't have wraps though.
Okay, and we say
Dots everywhere.
wrap up to 2 finger widths below the bend of the knees. Sorry, my hands are
No,
freezing.
okay.
So that's about 2 finger widths there. kind of tuck it in because it likes to unravel. And then the Coban. So back in the day, we didn't have circles on our 2-layer wrap compressions. Anybody remember that? I don't pay attention to the circles, but the patients do. So if they kind of tell you like, oh, you're supposed to make it a circle, you know, you can just make it a circle and please them. I use, like, I just know how hard I'm pulling. So, yeah, full stretches, circles, over stretches if you make ovals. So we don't want ovals, we want circles, or little tiny circles. But anyway, most of the time, we start out compression about 50% unless they are a CHFer. We kind of start out maybe with minimal stretch, like 25% stretch. But I'm going to start you out at 50.
I have a question.
Yes.
So I've run across this problem several times with weeping edema
Okay.
or stasis ulcers. When you go to take those off, there's calamine all up in the wounds. So, and they have fragile skin, so you just...
So we do purposely put calamine on wounds. It's to soothe something. You know, people come in with big edema legs and their legs
and
hurt
the
all
dry
over.
foam when you take out the wrap.
So if they're complaining of pain, of course you run warm water on it with a washcloth or whatever you guys do in the home. If the patients cannot tolerate it, that's when we would add a layer in between the calamine and the skin.
And that's usually the Metholex foam one.
Mepilex or sometimes we do put an ABD pad over that.
Yeah, I've done that.
Yeah, yeah. Or just Mepilex or Mepitil. I thought I brought a little piece last time, but Mepitil is just kind of like the outer Mepilex. It's a silicone layer with little holes in it. Let me see, because I had that last time.
So you can put that directly on the skin, you don't have to put it in between the layers.
Well, I think
or-
we've had a couple patients years ago.
Yeah.
Like
Because usually my
in
orders are...
between- In between the calamine and the other part of the ABD.
That's what I have in my
Yeah.
orders.
What did you have in your order?
Oh, ABD pad and then the calamine and
Yeah.
then, yeah,
Yeah.
like just last week.
Yeah.
Well, I think I've had cases you do the calamine, then the ABD.
I
Most of the time, that's
It's
what
supposed
we
to be the
do.
calamine first and then the ABD.
Yeah. But
Not
if
that,
pa-
not the ABD, because then the calamine's not touching the skin.
right.
So the IBD's supposed to go over the calamine.
This one was like profusely.
Sometimes we do odd things though,
Yeah.
so not every time we put the ABD pad in on top of the Coban or calamine. Sometimes we do put it on the skin. You know, most of the time we use a Mepilex dressing to the wound, just so patients don't complain of that pain.
Yeah.
The Mepitil, like I said, you can put as a contact layer to prevent the pain. And Mepitil, that is a dressing I forgot to mention. But if a patient has the big weeping legs and they're changing their dressing 2-3 times a day, you would use the Mepitil over the wound as a contact layer and then put your ABD pad over that Mepitil just so the patient can take off the ABD pad, leave the Mepitil on so they're not ripping on their skin. So you would just be changing the outer layer. And the Mepitil can stay, they can use it up to 2 weeks is the lifespan for the Mepitil. We do recommend that patients take it off every few days and rinse it in water just to freshen it up a little bit.
Wow.
All right, close your nose.
It's my bad ankle, I didn't know, I should have done the right one.
All right, again, wrap like this. You will have a hard time wrapping if you wrap like this. All right, and again, we're gonna start at the base of the toes. Oh, no.
I'm trying to help you.
It is hard to wrap like this, so it's not gonna be the prettiest wrap. In the video, probably can't see. All right, now this is where you have to pull for your strength. So I'm gonna wrap at 50%. All right, and this is where we will come around twice on the ankle. All right, now with compression wraps, the calamine does not need a 50-50 layover of each wrap, but the Coban, to get the nice gradient, even compression all the way up. This coband needs to be wrapped at a 50% layover, which means kind of like that. How does it feel? Not too tight?
Awesome. Leave it on all day.
I do when I get wrapped with practice. And I really see how much swelling I have at the end of the day.
Probably won't. This is I broke it 10 years ago and it's
Oh.
fixed by the end of the day.
All right. They do feel good when they're on, I think. Probably not for a week, but for a day. Our patients typically wear them for a week. Once we, the first, like if you were a new patient and you had a big swollen leg, I'd have you come back, what's today, Tuesday, Friday, for a nurse-only visit, because this will push the swelling out and it'll cause the wrap to slide down. After that, if the swelling is, you have a consistent reading when we check edema, then we can go weekly. If you have a highly draining wound, you might have to come 2 to 3 times a week. So then you just kind of
Smush it down.
smush it down, and then you get a nylon.
Oh, get your garter.
Yeah, some patients say, I don't want that, but then I explain, this is grippy, and you're gonna grip it in your blankets, you're gonna grip it when you're going potty, and you're pulling up your pants. It's a pain in the butt, so most of them will wear the nylon.
That is sexy.
There,
Mm-hmm.
all right. So that's a wrap. If you had big lymphedema legs, and you have kind of like, did you guys know pannus can be any structure with like an overlying skin? So it's not just a belly pannus, you can have a knee pannus
Yeah.
or an ankle pannus. But anyway, so if you had an ankle pannus, so we wouldn't want this wrap to create the pannus
Right.
to fold over and create
That's
that
right,
crease
but
in their ankle. So we build them up with ABD pads. And for a lymphedema pannus, I would probably cut this in half and go all the way around her ankle to kind of protect that
After the
crease
Coban or before the Coban?
against your skin.
Oh.
Yep.
Okay.
Yep. If you have a champagne leg, so if she has skinny ankle and then a big calf, we would also build it up with ABD pads at the ankle, so the wrap would be more even and it just wouldn't slide down that champagne leg. Use ABD pad to build up that, or cast padding. I really like cast padding because I can just wrap it around the ankle and build up that ankle piece.
And that goes on before the calamine.
Mm-hmm.
Okay.
Yeah, I mean, you can use it afterwards, I guess it doesn't really matter.
Oh.
If they're open and weeping, you would probably want the calamine and then the cast padding. But you really want to build up that ankle. You guys see it, you know, the oddly shaped legs.
Oh, yeah.
You just need to pad it up a little bit.
It's a shoulder patient.
Okay, what stage is this pressure injury? 4. Just bomb.
Yeah.
All right. So I cleanse with normal saline. I'm a good little nursey and I use my skin protection, right? My skin prep wipe on there. Alright. I always cut my drape like this, just to make it easier. I don't use the big honkin' sheets unless the wound is that big. Surgeons love to use the whole sheets and then they have to go in and take it all off and it's not nice. So I go doing that. All right, I'm going to show you 2 different ways how to pre-drape. Did you guys get those videos? Did you send those videos?
Yeah, I did.
Yeah,
Mhm.
I liked those ones.
Yes, thank you for that.
And these are ostomy scissors, so it's cutting kind of funny.
Not a video, right?
No, you're right there.
Ooh.
Wait, Mary.
Just, yeah, don't get a butt shot. Okay, so back in the day, I've been doing this a long time, actually, most of my nursing career. I used to cut strips and I would pre-drape and go around the wound with all these strips and it would take a long time. So this is one way to do it. But I typically take off the 2 first. so it can go around wound edges better and kind of manipulate this a little bit better. So
It's
one,
hard
two,
when you have your gloves on though.
yes, it is. So 1-2 blue, you guys all know that, right? And just like my compression wraps, I have a certain way that feels easy to me. If I am not taking off the 2 first, I spread my 1 pieces apart just because I feel like I can work with it better. I'm not going to go all the way around, but I'm just going to show you what I used to do. And sometimes we still have to do this. But Seymour doesn't, he doesn't like to be sticky. If you have a wound that has a little bit of depth, like this one, I would probably use the technique I'm going to show you. This one. But if they're more shallow wounds, I would probably use my strips. But for wounds, a lot of them you can just put a whole strip down. Most of the time you need like 3 or 4 hands when you're doing wound vacs, right? So you could be a perfectionist and take your scissors and cut perfectly around there. I don't do that. I am a perfectionist, but not with that technique. I kind of just take the drape and kind of roll it back. So then if you need an extra hand, the foam, this drape kind of holds the foam for you when you're working. This wound has undermining from like 10 to 2, just because I've been working with this a long time, I know that. Most of the time I use a cinnamon roll technique. I love cinnamon rolls too, but I use cinnamon roll technique where I cut a big long piece. Like a cinnamon roll.
I wish they just made that foam
They
that
do.
way.
They do. You can order it that way. Some wounds it works perfect. We just always have this type. Of course, you want to cut off these little edges because they do break off. They can break off in the wound. Most of the time I use my fingers. You guys can use a little applicator, but I just use my fingers to get in there. And you want to loosely pack tunnels or undermining. And the rule is with tunneling, if you can't visually see that wound base, you should be using a white foam. And I did not bring that with me, but it is a more dense foam and it's moist. And you would slide that in the tunnel instead of this, because you don't really know if you're getting all the foam out because you can't see the wound base. So anyway, I take the foam and kind of coil it up in the wound, lightly packing, just like a cinnamon roll. And if I cut too much, you don't want to cut over the wound, but you can cut that off. Easier on a model, but the edges do help hold the foam in so you have your 2 hands. Now this is the simplest wound vac you can have. Patient's
No
not
idea what
crying in
this
pain.
Never seen one done.
The simple belly ones are simple, you know, or the trauma legs that have perfect wounds. Most of them are not this simple. Okay, so if I were to dress this wound, if it didn't have any undermining or tunneling, you could cut a piece of foam. What size to cut, because I just know. Probably about this size, and it would just lay in the wound. You don't want to overstuff. We say cut the foam a little bit smaller than the wound, so the vac machine can pull it and suck it and contract those wound edges. So that's about that. Recommendation now is about a 1/4 size hole. I still see nurses grab tweezers and like lift it up and cut perfect hole. You're just wasting time. I pinch it and cut it. And you can even stretch it out. Most of the time I cut it and I still kind of stretch it out a little bit.
So I've had a couple patients where I've seen people actually take the foam down around the leg.
Mhm.
Is that acceptable?
Yes, and if this
Okay.
was a real life patient, I wouldn't put my track pad right here on the sacrum. I would, and I'll show you the bridging technique to bring it to a non-bony prominence. But there's a 1-2 on here too. I just take it all off because it's hard to pull off the number 2 once it's on the patient. Patients typically know how they like the cord, so I would ask them which way you like the cord. And then the blue just pulls back towards the cord. And he's not sticking, I'm sorry, but that's a wound back. One time I was stepping on a cord when a patient stood up and we ripped the back off. So most of the time, all the time, I use a extra little piece here and kind of pinch that cord and kind of secure it on. Just gives it an extra little protection. Even if you forget it on the counter and the patient walks away, at least it's going to kind of tug on the cord first. All right, that's a super simple back. So if you look up KCI videos, they do not pre-drape. It's an institutional recommendation, and I recommend pre-draping or picture framing the wound, and that is just to protect the good, healthy peri-wound skin. If you have black foam on a piece of skin that isn't protected, it'll create a hickey and skin irritation and cause it to weep, and it'll be hard to keep doing the back dressing. I'm just going to cut this to show you the all right, so if this was a real life patient and they were in the bed on an air bed being compliant and you know, turning every 2 hours, this is how we would dress this wound. So we would come up, most of the time we come up to a non-bony prominence. I call it my love handle. I bring it up to their love handle. No black foam touching intact skin. Do you guys have to go? No? Okay. All right. I'm just going to work with what I have here.
Thank you.
Oh yes, thank you. I'll see you around. So here's my little bridger. Of course, you want black foam to touch black foam. Not too long ago, I had a lady, she had a wound up here, and then a bridge of skin, and then a wound down here. And there was black foam in both wounds, but it wasn't bridging. The black foam wasn't touching the black foam. So the vac was only sucking on the one wound. The other wound just had black vac foam hanging out. So you want to make sure if you're bridging 2 wounds, the black foam needs to touch black foam. So most of the time I would just cut a hole here. So I'd cut a hole and make sure black foam's touching black foam and bridge it up to their non-bony prominence. If they have wounds on the ischium, which are your sitting bones, a lot of times we bridge it to the anterior thigh.
So can you put the,
Then you put the plastic back on?
Yep, so this
so you can put the little round thing,
up here, yep,
okay,
yep.
that
You
was
don't,
my question.
yep, I should cut that off, but yes, you would, that's why I have this little thing. So you need enough foam for that track pad to sit on. So I would just bridge it up there, put my drape, cut my quarter size hole here, and put my suction up here.
And even though, because it's touching the inside of that wound, but that other end of that is not, it's on good skin.
Yep,
Okay.
because it's on drape. I laid down drape first. We see that a lot.
Oh, you lay down the drape first?
Yep, we
Okay.
see if you're bridging, you need to make sure you're
There's drape
laying down
on.
drape
Okay.
wherever there's black foam.
And then drape on top.
Yep, yep. So just like this one, but just up here, and the suction foot would come up here.
Okay.
We do see patient, or whoever does wound vacs out in the field will do it correct here, but then lay the foam down without drape, and they come in with a big long hickey mark. Yeah. Okay. that's it. There are some wounds, like we have a scrotal wound that we're doing that you just really can't pre-drape. There's not a lot of room. It's kind of like a moist environment. So we just make sure that we are cutting the foam the exact size to fit directly in that wound.
Scroll.
Shooting that.
No, Fournier's green.
Oh, yes.
So we do get a few of those a year, poor guys. But if you don't control your blood sugars, most of them are diabetics, uncontrolled, smokers. Those are most of our Fournier's gangrene people. All right. Any questions about wound vacs? Just make sure black foam's touching black foam. Like that lady, I would have done a dressing here and then laid drape down on that intact skin here, put foam in her wound, and then laid over a big piece
I
of
think I
drape.
had a lady like that that had a wound up above, so I put some here, some in there, and then I put the tape down here and then connected black to black.
Yep.
I had to do it that way.
Yep. So what I
And then it
would
didn't matter where I put the suction, it was either on either wound, right?
Yep.
Yeah.
Or sometimes we put it right in the middle. I mean, it's kind of weird that KCI says the suction is 125 straight across the board, but sometimes I feel like it's not. So sometimes we put it over the suction foot over the deepest wound because we want the most suction there. You know, a lot of times if we're bridging two wounds together, I'll put it in the middle so it's equal.
Yeah.
But yeah, just make sure foam's touching each other. You need enough foam for the suction foot. The suction foot is actually what senses the suction, you know, the 125. So you definitely need your hole cut big enough to fit this suction foot, and you need enough foam. Several times we have nurses call us with a post-op patient from the OR, and the doctors just put in enough foam for the wound and that sucks all up, and then the suction foot hardly has anything. Like you go in there and it looks like there's no foam. So we have to cut the foot off, add more foam, put the suction foot on there so it can sense it.
Is it ever a different suction setting or is it
Yes,
standard?
yes. So all the machines are pre-programmed at 125 because that is typically the standard. But if a doctor is worried about creating a fistula in the abdomen, and we do that a lot on first floor, where Ashley came from, we would bump it down to 75, just so we're not sucking on those intestines and creating a fistula. Yeah. Some diabetics or even just normal patients with a deep surgical wound on the foot, we would increase it to 175 just because we feel like we're sucking more blood down to that wound.
Question, this is off the subject. The wound that's in the gluteal fold in there. So to me, I've seen, you know, how your crack ends and then it kind of like, it's almost like you were constipated, it's kind of split a crack. To me, that's not a pressure.
No.
That is just a wound in the gluteal folds, okay.
We would call that most likely a moisture associated.
Yeah.
Yeah. Just those butt cheeks are.
Some people have
creating
been calling them that,
moisture.
but I think you're not sitting on that, so that's not a pressure because.
Yeah, a lot of times we see this a lot in the hospital because you're moist, and then you boost them or you turn them and you're stretching those cheeks apart and you're just kind of like ripping them apart. So yeah, and
I've
I
had
would
a
just do
couple
barrier
people
cream.
get those because they were constipated.
Yeah,
And then they kind of,
yeah, yeah. I would do barrier cream. Any burning questions about anything?
I'm
About
just
wound
curious
care?
about changing the canister, just because I've never had to do that before.
Okay, and I wish I brought one with me. But the little wound vacs that you guys see,
Yeah.
you go to the side of the canister and there's kind of like a lever in there and you just pop it down.
And it just pops out.
And it pops off, but sometimes it's stubborn and you really have to like
Okay.
shake it and
most of
rip
the
it
time
off.
the patients know how to do it.
Okay.
Yeah, so then you just grab the canister and put there's kind of like a little thing poking out. So then you just match up the hole with the canister and just pop it back on.
Do they usually have a spare one in the home?
They should.
Yeah. Or
If they're,
can we bring them? Or
We don't
they
have
should
any,
that?
we don't,
Okay.
we don't have these.
yeah,
They have
so,
to have all the stuff.
yeah, when
Okay,
they're
okay.
discharged from
Should have been
home.
ordered.
Should
Yeah.
have something like that.
Yeah,
Okay.
so the pack that it comes with 5 dressings and 5 canisters.
Okay.
And then they have another set being shipped to their house.
Okay.
But that brings up a good
So don't
point.
show up to the house and need a canister and be like, oh, there isn't one. Or like, you never know.
Yeah, well, then you can do a wet to dry dressing and you're gonna suck it in.
Yeah, if they
Yeah.
have a full canister and it is alarming full canister and they don't have one, yeah, I would do a more conventional dressing.
Okay.
And we have a lot of donated supplies, so if a lot of patients can't afford to pay for the supplies, so we kind of just give them our donated dressings too. But back in the day, it used to be home health nursing would keep track of the supplies at home and order on the KCI website when they needed more. But I don't think we're doing that anymore. So, I mean, that's just good for us to know because that's, oh, they have home health, they're ordering the extra dressings. But no.
Oh,
We
bring
don't
the
order them, they're
supplies
supposed to be
out.
open.
I've heard.
Okay, so I'll tell my crew that we should, yeah,
And there's a lot of stuff that you guys have that we don't have,
yes,
so.
yeah.
And the honey.
Oh,
Meta
Meta Honey, I'm so glad
Honey
you brought
has been
that
a
up, I didn't
huge
even
thing.
go over it.
Yeah.
And it was on my table. And I have, wow, I kind of skipped over a lot. Marathon. So if this guy came in with his wound and he was macerated and that skin was kind of lifting up, we would use Marathon kind of around the wound edges.
We were told that can be used several times to put it in a plastic bag, because they're very expensive.
They are very expensive.
We don't use them as a one-time thing.
Yes, and that's okay, and we tell our patients that too. This kind of gets hard. I use it too, like if I have a cut on my finger and I'm working and the alcohol just hurts it so bad. I use the Marathon and it lasts like all day. I mean, it lasts all day, all the washing, all the alcohol, it stays on there. But yes, a vial, if you were to just buy a vial from Prism, which is where we order our patients' dressings, they're $27 to $35 a vial.
Oh,
Expensive.
A vial, yeah. So I do tell my patients that you can put it in a Ziploc baggie, but the tip will get hard, so you kind of have to trim away the hardness, you know, the dried Marathon. But most of the time we use this with ostomies, and I'll go over that when we go over ostomies. But Meta Honey isn't covered by insurance, so a lot of times we give the patients the tube when they leave the clinic, or some will order it off Amazon. Patients order dressings off Amazon, cheaper price. Parthenon is a cash basis thing. A lot of patients that can't afford ostomy supplies because they are $500 to $700 a month. And if your insurance, or if you don't have insurance, they go to the Parthenon, and you can just, it's a cash basis, then it's cheaper. So our patients go on Amazon, just Google dressings. But anyway, Meta Honey isn't covered by insurance. And we use this on wounds that need debrided, but patients either can't tolerate the debridement, because it is an autolytic debrider, and it's the only autolytic debrider we have in our clinic. That's cheap. Santal, we have ordered that in the past, and maybe podiatry, maybe you still see it out there. It's like $500 a tube for Santal. So anyway, autolytic debrider, it does suck fluid out of wounds, so you will see increased drainage if you're using Meta Honey. And all you need is a little dot. If you have a wound, I don't know, this size, I would put just a little pea size on my Methylex, on my dressing. I wouldn't smear it all over the wound. I just put it on my dressing, put it on the wound, because it'll melt and kind of go all over the wound. And these dressings typically need to be changed daily. So we typically do Meta Honey to gauze. Sometimes we will use Methylex, and patients will just kind of lift it up and add a little bit more every day. Anyway, Meta Honey.
I have a patient that's, Meta Honey on the Xeroform, you probably know who I'm talking about.
I don't know.
Because you see this
I've seen
patient
that a couple
every week. So, so if the Meta Honey's supposed to dry, why are we putting the Xeroform, the Vaseline?
It's not supposed to dry. It'll stay moist.
Okay.
Some patients can't handle the pain with removing the gauze directly from the wound in the Meta Honey. So the Xeroform is probably just a comfort thing.
Okay. Good to know. Thank you.
Yeah, a lot of arterial patients have severe pain with the dressing changes. So Meta Honey and Xeroform, we do that a little bit, not too often. And hydrogel, I didn't go over hydrogel, but I brought that. I love hydrogel. It's like 99% water. It's soothing. But you can use this to keep the muscle bone tendon moist.
So where would you put that, in the big wound?
Yeah, I mean, I wouldn't really put it, kind of a necrotic wound. Because to me, I used to be an inpatient wound nurse and we had no wound providers, so I was kind of on my own going through the hospital, and I can't really sharply read. I always use Meta Honey and Methylex and keep that on there for 3 days, and you would go in and it kind of liquefies that fluffy dead tissue, and I could just wipe it and clean it up. But yep, it would put it, either squirt it in the wound if it's big enough. You know, this one would be a
And that's
good
called
one.
what?
Hydrogel.
Hydrogel.
I would squirt it in the wound and cover it with the dressing. Yeah. We go in kicks of this too.
I don't think we have any of that.
We do.
Do we?
Yeah.
Yeah, because we haven't used it.
Yeah. I always remind our providers, what about hydrogel? It's soothing, kind of helps liquefy dead tissue. Anything else? No? Okay. Did I miss anything on our list, Carrie?
Nope.
Okay. All right, ostomies. Oh, gosh. Let's move everything. All right. I love ostomies. Not love them, but I love getting those patients and helping them become independent and feel comfortable in changing their stuff. All right. So I'm going to just go through how I initially teach my patients, and then we can answer questions. I did bring some pictures. So we can kind of troubleshoot some. All right. You guys get fresh ostomies all the time, right? You do?
I need a home health, so I haven't seen any questions.
Okay, so I teach my patients, they're fresh post-op, their stomas are like mushrooms, they're big and swollen from the trauma of surgery. So I go in, I take off the appliance, which you have to do carefully on fresh, well, you have to be careful all the time, but especially with fresh ostomies because they're swollen, their skin easily strips off. So I would use adhesive remover, and when I've taken it off the patient, I use the adhesive pad and then I kind of use my thumb to separate it from the skin so we're just not yanking on the skin. Some patients form blisters under this fresh post-op just because they're so swollen, and you just need to be, I mean, you're ripping off their top layer of skin. We just have to be super gentle. But anyway, I didn't bring a measuring guide, but have you seen the measuring guides? You know, the ones with all the little holes in them. We direct our patients, we need to measure your stoma so we know how big to cut this appliance. We recommend only cut it bigger, no bigger than 1/8 of an inch bigger than the stoma. You want hardly any skin showing. So I teach my patients to, you guys have ostomy scissors? Yeah. Get the wafer back in the scissor and kind of just cut and move the wafer so you don't get the jagged edges. I just worked with these models so much. I know exactly how to cut it. But anyway, so that looks good to me. There's kind of a little white showing. All right, and while your patient's laying in bed, you can say, Mary, put this underneath your armpit and warm it up for me. You know, I put them to work. This is a berry ring. Paste is out. That's old school.
Yes.
So we don't have paste in our clinic whatsoever. We only have barrier rings. We only use paste for nothing else is working. So we're like, let's just give paste a try.
Do you always use the barrier ring?
When I teach my patients, yes,
Okay.
but I tell my patients, when they're independent, you do what you want. I mean, if you're not having leakage problems and your stoma is perfect and you're changing it just twice a week or once a week, sometimes they get rid of the ring because it's just an extra step to them. You don't have to use a ring, but we teach that in the hospital. So there was 2 sides to that, so just make sure you're taking off both sides. And I kind of stretch, well, you gotta stretch it out. Some people rip them apart and like lay them around like that. I don't. I'm not lazy, but I try to be efficient with my time and my patients. So I take this backing off, and I keep that as a guide for the next time I go in. I always fold down my tape, and I put the ring on the back.
That's what I do too.
Yeah. Nurses, even the nurses in the clinic, we all do it different. I do this, unless it's a real wonky, I guess, stoma with a wound or something. But I most of the time just put it on the back, and I pinch it up to the edge of that wafer. I'm paranoid that this wafer is gonna rub on the stoma and cause a laceration or a trauma. We do see that sometimes when patients are cutting them too small. All right, so that's what I do. And then we just put it right around. I take my finger and I go around, trying to really make that good seal. Take off my tape. Alright, and that's pretty much it. Uh-oh, I wonder if I didn't bring another pouch. Oh, I did. I just didn't, I just grabbed a disposable one. So I'll use the one piece just to kind of show you the lock and roll part. But the lock and roll, that's kind of newer too. We don't order the clamp ones anymore at all. But we do make that assessment when we go in and see the patients. If they're arthritic and they can't fold up this pouch 3 times, sometimes we will order the clamp. So we just pay attention to their dexterity when you're in there. But if you have a fresh pouch, I am teaching, I didn't know this for a long time, but these pouches are hard to open when you're like trying to drain the stool for the first time, you know? So I take the pouch and I fold it the opposite way and rough it up. So when the patient is trying to empty, it's way easier to kind of open. But you just roll this up 3 times. And then there's a tab, and you just kind of pinch that all together. Call it medical grade Velcro. And that's the lock and roll pouch. It is harder to me than the old pouches to kind of clean them. But I tell patients just kind of grab a piece of toilet paper and just wipe around the bottom and then just fold it back up. It is harder to clean it. We have some patients that only want clean pouches, so they like try to take off their pouch and rinse it out with water and let it dry and use it forever. If you do have Medicare, I think they still cover for 2 pouches a day, I think it's 2 pouches a day. I know it's 2 pouches a day for the disposable ones. It might not be 2 pouches a day for the drainable ones, but I mean, you can change it at least twice a week to have a fresh pouch. You don't have to rinse it. Some patients do, and they insist that they take it off and clean the stool around here too. We recently had a patient just say it's leaking all the time, and I'm like, okay, well, tell me what you do. You know, and every time she empties her pouch, she takes toilet paper and wipes that off, gets a Q-tip and gets around the edge. Well, it just lifts it up, and no wonder why you're having leakage issues. So Just drain the pouch and leave the pouch on. Yep. Drainable ones, or disposable ones, we would use for colostomies once their stool returns to normal stool consistency. So you might see these out and about. But anyway, these flanges have, they're called accordion wafers because you can fit your finger under there. The model is hard to snap it on like that, but it just snaps on like a Tupperware lid, so you're not pushing on the belly. I'm gonna push on this because it's hard to get my fingers under that. But that's it.
So now I had a patient who I saw something new that I had actually not seen before. That same setup, but he also had a hernia, and it was the weird, I actually sent it to you guys. It was the weirdest colostomy I've ever seen. Okay, and it was long. It was like this, but he had a hernia underneath that was pushing it, and so we were using those, what
Yeah,
are the?
they're like pedal, they're called like pedal.
Yeah.
Did you see those?
Yeah. So I did.
Was it Coloplast?
Um,
Coloplast is the only one that makes
it
the
might have
pedals.
been. Yeah, and they were they were almost thick around the edges, like almost like a Meplex. And then it just, he made me put 3 of them on, one on the bottom, one on
The barrier strips?
Yeah, barrier strips, so that it
Oh.
wouldn't, like it kept, because he kept pushing.
Yeah, so those are barrier strips.
Okay.
Some come in like kidney-shaped ones.
Yeah,
some-
those were-
Yeah.
Oh, I've used those tons of
I had
times.
Yeah.
never seen them before.
Oh, they're
Right.
so nice.
The
Never
strips,
before.
yeah, you could make a whole round
I
thing.
was
if
like,
you
what
want.
are you doing? I was like,
Oh.
what is this?
Especially if they have, if they're protruding
And that's
out.
exactly.
Yeah.
So
what
some
it is.
patients, yeah, love the barrier strips for more security, like they feel it's like more secure on their belly. Most of the time it's used because of leakage issues
Okay.
or hernia. It's hard to get a square around a lump without wrinkles, so sometimes patients just feel like the barrier extenders
Yeah.
help with that. I love using barrier extenders under wafers instead of thin Duoderm if there's a
Okay.
wound issue. So if a patient has those
Uh-huh.
and you're dressing a wound, let's say, let's see if I have this one, this gal. She ripped off her appliance and created skin stripping, and it necrosed and became a big old wound. But anyway, on her, we were using like Aquacel, a strip of Aquacel under there, and then her, we were probably using thin Duoderm to cover it, but you can just cut the barrier extender. I like the material of that better. It's soft and smooth. Put that on there, and then you would put your appliance over top.
Okay.
So you would just put the barrier, the thing right directly on there.
Just cut enough to cover the dressing. You don't need the big long strip. But that's how I would treat this wound. Not every single wound like this. This is denuded skin. This is just from the stool burning their skin off, pretty much. I wouldn't use Duoderm under here. I would use my Marathon. I'll tell you my initial assessment. If I see this patient for the first time, I'd be like, wow, in my head, I already know my go-to is gonna be Marathon, convexity, and a belt. Those are three things, my three.
What's convexity?
Convexity would be
Oh, okay.
this. So instead of a flat appliance, it has kind of like a bubble. But on her, I know that she looks, it's hard to see in the pictures, but looks like you have some creases going on. So I would switch to convexity, because in the hospital, we only teach flat. You're not really supposed to use convexity on a fresh post-op patient right away, because we don't want to put pressure around that skin and rip that skin around there. So if she comes in, those are the three things that I would try first. Marathon, I would use barrier ring, convexity, and a belt. And she'd probably have to change this every 2 days. Sometimes patients are weeping so much they need to change it every day with the same system. And most of the time, I would say probably 95% of the time, just with those 3 changes, it solves the problem. Her, we already talked about her. This person, I would also use probably some Aquacel in those wounds, and then cover it with a thin Duoderm or a barrier extender, and then the appliance. So let's say, because we've had this, patients sometimes have an allergy to Marathon, and we burn their skin even more. So we go back to old school crusting. It's not old school, but since we have Marathon, that works so awesome. Sometimes we forget about crusting, but you can crust. So crusting. I will Marathon.
That's the power.
Yep. So on her, well, I don't need to take it off, but I would sprinkle the powder all over. I would take a Kleenex or a gauze and dust off the excess. And then I would take my skin prep pad, and you're just gonna blot it. You're just gonna blot the powder, because it creates a crust when it dries. And I normally do crusting twice, so then I would add more powder, dust off the excess, blot it. You can do it up to 3 times, but I feel like it builds up too much and the wafer doesn't like that.
So if that's something that you're doing on a patient, like that would be written out in our orders. So
Yeah,
we
it
can
should.
follow. Okay.
Yeah. So if a patient comes in with mild redness, we don't do really much of anything. You're not supposed to use skin prep under ostomy appliance anymore. That's kind of old school, that's gone. So just use the vacuum material now has ceramide in it, so it's supposed to be soothing. It's supposed to keep the skin healthy. So with mild redness and irritation and even a little bit of weeping, I would just use the ostomy appliance, no skin prep. This patient, we could, if it was less denuded, I would probably try crusting first, because that kind of is the standard, crusting. But if this patient comes in, I'm gonna skip crusting and I'm gonna go right to the Marathon. But if patients have an allergy and it's the cyano, it's the cyano, I can't ever pronounce it, the cyanocritlate. Some patients are allergic to it, and it's like the skin glue in surgery. So that was the patient. He's like, oh, I had a glue allergy. And it was like, it's the same, if you look up glue that they use in the OR, it's the same stuff. So we had to crust, and it worked. That's probably kind of what your guy looked like, but he was probably prolapsed more.
Yeah, he was way prolapsed.
Yeah. And that's just, sometimes there's nothing you can do about it. Sometimes patients are like, I'm going to live with this for the rest of my life because there's no way I'm going into the OR again. And sometimes they're like they're just so unhealthy, surgeons can't operate. But that is a periostomal hernia. Looks like a third boob is what it looks like.
I thought I remember in the past that I had a patient that had a binder with a hole.
Uh-huh. So sometimes we do measure for hernia belts, and we do measure, some of the hernia belts have a prolapse tab, but for your guy, it's probably too prolapsed that it won't even work.
Like 3.5 inches.
Yeah.
Yeah.
So, yes, we do measure for hernia belts. Sometimes patients don't want hernia belts, or sometimes they're 2 months out from getting them because of the manufacturer. So sometimes we just get an abdominal binder and cut a hole in it, and it helps hold that hernia in there. But if this was a healthy patient, I would say you were making an appointment with your surgeon and see what they say. Sometimes they go in and fix the hernia. Sometimes they just fix it when they do a reversal. Sometimes patients just live with it. This one is mucocutaneous separation. So that's when a stoma is created, the surgeon brings it out of the belly, mushrooms it, and then sutures that stoma on there, and the sutures eventually dissolve. Sometimes those sutures break away and cause the separation, so that makes a wound. So for this lady, or guy, I don't remember who this is a lady, it's kind of funny when you know them by their stoma. You just look at a picture and you know them, or their feet, like you know who they are. But her, I did Aquacel, and then I used my wafer. I only cut the wafer the stoma size, and used my wafer to kind of hold on that dressing. So you don't always need a thin duoderm or barrier strip. It's recommended to still cut the size of the stoma, so still cut the size of the stoma and use the wafer as the dressing over that Aquacel.
Does that eventually heal?
Oh yeah, yep. And the patients are like, what about infection? There's stool always in it. There's stool's gonna get in it no matter what. And most of the time, generally, they don't get infected. As long as you're cleaning it with your change, it'll.
How often do you change that with the officer?
Sometimes we change it up to 3 times a week. Sometimes the wounds drain so much. Sometimes it's an island, like a whole moat or whatever. And sometimes those need to be changed every day. Or sometimes, if it's awful, like in the hospital, sometimes we see awful things. You can use a wound manager, but there's one that has a window. So you can just open up the window, change the dressing, and close it back up. Yeah. This little lady, she is like 72 pounds.
Oh dear.
Oh my gosh, that's in.
I mean, she's small. She's like pediatric. So her bone was so close to her stoma because she was so tiny that it kind of popped everything off that we were doing. So we switched to just a one-piece. So she is living in the one-piece system. It's more flexible. It doesn't care if her bone is trying to pop it out. Young active people, a lot of times we do the one-piece because it's less rigid than these two-piece systems. And for her it works. So I saw her and I did marathon. I did a slim barrier ring and then a one-piece. This is kind of a healthy stoma. That's what we like to see. It's slightly budded so everything will shoot in the right direction, hopefully into the pouch. That's necrotic stoma.
What do you do for that?
So, especially in the hospital, I would call the surgeon and say, you need to come look at so-and-so stoma, it's black. They will come in and insert a test tube sometimes and shine a light in it. And if they see pink down in there, it's viable. Some have to be taken back to the OR and have their stoma recreated. It's just a blood flow issue. If blood flow was lost long enough to the stoma, it dies. But a lot of times, this will just necrose and you'll be left with a pink stoma underneath. But this is kind of like a marshmallow. And when I first started working with stomas, I'm like, oh my God, what is going on? And I'd have to call in like this charged surgical nurse. And it's really just the stoma sloughing off. And you don't really want to debride it off. I mean, with every change, it'll loosen up and come off. But it's like a marshmallow, like a burnt marshmallow, and the top layer is going to come off and you're going to be left with a pink stoma. Hopefully not at any, but a lot of times you're left with the any, or something that has creases at 3 and 9 o'clock. So for this guy, if they're standing or laying, they don't have any creases, but if they're sitting, I mean, we all have them, creases at 9 and 3 o'clock, I call it a poop chute. Your poop is just going to shoot out either side under those creases. So I build up those creases. I use a barrier ring. I roll a worm. And just break off a piece. Roll it like a worm. And put it in those creases, there and there. Then I would still use a barrier ring and a wafer. A lot of times for creases, or that little, what is a saggy one, like this one that you can use convexity to press out those wrinkles and create a hug right around that stoma. But this guy definitely I would use roll worms. And a belt probably. Oh, this person is just awful. A lot of urostomies kind of just become little holes in bellies. You don't really have a stoma to work with, you just kind of have an opening on a belly. Here I would probably do marathon barrier ring and try one piece. Just a belt maybe. That's pretty much it. I mean, this is kind of like the total dehiscence of the stoma. We've seen much larger than that. And again, I would just cut Aquacel and kind of lay it all the way around. Cut my wafer just as big as the stoma, or 1/8 inch bigger than my stoma, and put it on.
So if we see that,
Carrie, we have to get orders for the aqua cell underneath there?
Yes,
Okay.
yes, because that's a,
Yeah.
And this
you know, I
guy.
wanted to, since you brought that up, I've been thinking in my brain about these creams. I think the reason why we wouldn't have to, and I will, plead my case with us, that we would have to get orders for it, because it's a lotion versus a medication. Like if it had the fungal, antifungal, that is a medication.
That's my
The
statin.
The Intradry has medication, it's got the zinc in it. Not zinc, the sulfa, those kind of things. Isn't that kind of the mindset behind that?
Well, and that's the mindset of the barrier because it has zinc in it. It's a kind of a medication, but it's a standard of care to me, and
Yeah.
we
we
have
should
it
look into
covered.
that, 'cause-
Yeah, we have it covered under our policy, and it's evidence-based. I mean, we have.
If it's under your policy,
Yeah.
then I will look at that, because that's what we go by. And with
Evidence-based, yeah.
the dry dressing, it used to be we could only put gauze down, but you're telling us Mepalex is a dry dressing that can be placed on there until we get another order.
I would say yes.
Yes.
That's what we do.
We need to research that, because that'd be so much easier.
I will take care of that. I will
Going into house,
research
I need it.
Well, and
put
like
it
I
on
said
there.
earlier, the problem is I come out, I see a stage 1 or a stage 2, and I'm like, we need to do something about this.
So
Send
what
the
do-
doctor a note, and it takes a
Yeah.
week.
Sometimes
So
at
what
the
do
end,
you-
you don't even hear back.
What do you do if you go to a home and you're like, oh my gosh, I need a heel lift boot?
Oh, shoot, I treat it, and then I write orders later. or,
But how do you get
request
the heel
orders.
lift boot?
A heel lift?
Yeah,
I
like
don't know what that
a
is.
Z-fold boot?
Is that that liquid?
It's the, yeah, it's the.
We have to
I
order
have
that
to get
one.
an order
We
for
have to
that,
get an order.
yeah.
We are required to write an order, to get an order signed before we start wound care. We are covered by a dry dressing.
But we need to get that changed, because
Sometimes
if you
you
send that to
My
the VA,
patient
you don't
like
hear
that.
for 2 or 3
My
weeks.
patient
I
has
know.
stage 2, I'm gonna take care of it, and
Yeah.
then.
And if
you
we
know.
have that, is that's
You don't
part of
put
our standards of care,
gauze on it?
the hospital, we are the
No,
hospital.
because that's not gonna,
Yeah.
I mean, like, you know
Yeah.
what I mean? But that's me personally, and I
But
don't
if
think
you
folks
are
know.
documenting that you're doing something, we just had something, a big thing, the whole chart is not gonna be, the whole episode is not gonna be paid for,
Okay,
because
then
someone
I
did
think
something without a doctor's order. So it's huge. Yeah, it's huge. Just yesterday, Helen came to me and said, look, we can't, they're not gonna pay for this. This is not billable because it was done without a doctor's order,
How long,
so.
you don't have like, you can do something and then you, within 3 days, get an order, then it's covered?
We don't
You
have that,
have to
but
have
I
an
will
order.
go back and talk to them about that,
Yeah.
because
That's
it
hard.
is very difficult. I guess if I had a bad wound, I would send them into you guys the next
Yeah,
day.
and you guys are good at referring patients.
So
our way
what's
if
the
needed.
case about, like, I've had patients that come from the hospital home, and the family's already putting that stuff on.
Mhm.
I'm gonna send for an order, and I might document that the family is applying that, because they got it from the hospital.
Yeah.
Right, you can do that, the family is applying for
Yeah.
this, but you can't put it, you can't be doing it yourself.
Right.
I mean, that's just, but you're requesting orders for this.
Yeah. Do you have questions online?
This is Dana. I have a question. I'm over in Libby.
Hi, Dana.
Hi there. So I have a patient I just discharged last week who has a new ostomy, was doing great. And you guys had set her up, at least I'm assuming it came from you guys, to set her up with the Hollister Sure Start. Because when I called to do it, they had said they already sent a pack that someone else had called, and she was going for wound care too. Patient didn't get the pack, so I set it up again, and then I called the patient to make sure she heard from them, and she did, but she said that Medicare does not cover a lot of her stuff. Can you tell me a little more about that?
Yep, so every patient in the hospital that we educate on and that we're able to see, we set them up with a Secure Start, and that's only samples. It's free samples from the Hollister company. They might send a couple different type of wafers, pouches, but we can check to send powder, barrier rings, adhesive remover, skin prep, a belt. We always order a belt if we're doing Secure Start, and that's just a free service from Hollister, but that's not the technical order, like you still have to do a different order to get them their supplies monthly. But anyway, if they're coming from,
From Hollister, oh, I was just gonna interject, doesn't the person from Hollister, once you get the ball rolling, they should take the bull by the horn, see what the patient likes, and move forward from there, correct?
not necessarily, no.
Yeah.
So typically in the past, and you guys can correct me, but in the past, if you guys have an ostomy patient, we set them up in the hospital with the Secure Start stuff just to get their supply closet built up with accessories that insurance doesn't pay for. But if you guys are seeing them, you guys bring them the ostomy supplies, and then when you're about ready to discharge, I thought it was the home health nurse's responsibility to set them up an account.
Yeah.
Well,
so
Hollister's
show-
gonna talk
get
to
in the
them
book and
until
circle
we
what they're
discharge
supposed to be ordering.
And it's not Hollister, it is Byram that we
Right.
order supplies from.
Right.
So,
Yeah, they can't do anything until we discharge them.
correct.
Because Medicare won't cover.
We have to
Right.
cover until we discharge them, but
Yeah.
you can show them the book and what they need to order.
Yeah, but, yes. So what do you guys do?
So we bring in
Because
the book,
the
and
catalog,
then whatever we've been using, we circle what they're supposed to order. And then they just can, write it out, so then they know what, when they call and order it, they have it right there. They know what to
Okay.
order.
so problems with that, so if I have a patient go home straight from the hospital, I actually call Byron myself and set up their account and make sure that they're faxing the surgeon, because sometimes there's a delay and sometimes patients are left high and dry because it takes 2 weeks to get supplies.
We usually set up an account before we discharge them.
So you call Byron?
Yeah,
And
I
set up the
have,
account?
I haven't had to do that, but I know that people have called Byron, and then they have the account set up. Because at least we wanna, if we know we're gonna discharge them in a couple weeks, we wanna make sure they have those supplies before we discharge them.
Yeah.
We can bring out, somebody, I think they said, 2 weeks of supplies at a time.
Okay, and that's what we do in the hospital, we set up the account, and it is the patient's responsibility. Once you're discharged, you call Byram and say that you're discharged, and then they'll ship. Yeah, does that answer your question?
Hey, Shannon?
Yes?
Well, no, I haven't contacted Byron. I guess it's my ignorance. I've done this Sure Start thing, and they've contacted the patient, and it's moved forward from there. I've never had anybody say they weren't able to get stuff. So am I doing this wrong?
No, I set them up.
Well, that's not how I do
And they go from there.
supply orders. Maybe if the patient says, I need to order supplies, maybe the rep on the phone will point them in the right direction. But me personally, because I don't want my patients left stranded, I personally make those accounts.
Okay, well, I didn't realize that. Okay, so back to my original question. Does Medicare not pay for all their supplies? I thought it would.
They pay for very basic. They'll pay for, I think it's, 20 pouches and 10 wafers and 10 rings a month, I think. The very basic things. But
Okay.
if they want a fancy pouch, sometimes insurance won't cover non-standard things or accessories. Like, I think maybe the powder won't be covered. Marathon's definitely not covered by insurance. Maybe sometimes the adhesive remover won't be covered. So yeah.
If a doctor orders any of that stuff, if there's a doctor's order with it, will they cover it?
There have to be a doctor's order for all this stuff.
Yeah, no, most insurances, especially Medicare and Medicaid, have a standard that they pay for. If patients want extra, they have to pay for it.
Okay.
Yeah. And sometimes there's medical necessities, like if you just have a leakage problem and you can't get a handle on it for a long time, sometimes doctors do write a letter and it will be approved, but that's very rare.
Okay.
We do have donated supplies, so a lot of patients do come, because Byram, there's a national shortage, or people just don't wanna work, so they're not manufacturing it fast enough. But we've had patients come in that have had a 3-week delay or a month delay on their supplies, so they're left almost a whole month without supplies. So we have those patients come in quite a bit, and we have donated supplies that we give them. But- Any other questions?
Have they come up with a solution to the melted wax ring covering the stoma?
No, and sometimes that happens, especially over little tiny urostomies. It kind of melts and occludes that stoma, so that's when I would back off of the ring and
I
try.
tried everything under the sun, and I'm not sure how she finally got it corrected, but I got an email last week asking me that question about how I took care of it, and I directed them to the patient to see how she found it, because I had her arguing with Byram, and Byram didn't have an answer of why it was melting the way it was.
Well, it's common, especially if you're, I mean, some of these little stomas, especially urostomies, get to be so small. I mean, I had one patient, that I didn't even have to cut this hole.
Right.
That's how tiny that ended up being. So the wax ring would just warm up and kind of move in and occlude the hole.
Well, and even that wax will do it on her.
It's probably,
The wax,
yeah,
it's her
because it's probably,
chemistry.
yeah,
It's gotta be, but it
it's probably collecting up that moisture and swelling.
could be.
Sometimes there is 2 different type of backings. There is a standard wear and there is an extended wear. And the standard wear, I believe, is meant for wicking up moisture, but to be changed more often. So sometimes you have to look at extended wear is more tacky and sticky. It's meant for like more colostomies, that don't have a lot of fluid. But the standard wear, you would be changing it more because it's less tacky, but it absorbs more drainage. So that could have been her problem too. So then I would just order the extended wear and see if that helped.
Yeah, they were sending her some samples to try
Yeah.
to see if they could correct the problem. but-
Yeah, I did have a little gal, I felt really bad, she was in her 20s and ended up with a urostomy and colostomy permanent. And we were having issues with her urostomy because it was that big.
Right.
And she ended up going to a Coloplast product, and I'm not really brushed up on Coloplast because we use mainly Hollister. But she used a 1-piece Coloplast without a barrier ring, and she has no issues anymore. But, yeah. Anything else? Did I miss anything?
No,
I think, this is the questions I got from you guys. I think you guys wrote in questions, and I can go over that. A box of 10 of Marathon, somebody asked how much Marathon was, that was a question. The hospital, we get it for about $46 a box of 10. If they were to order a box or just one vial, this little vial I showed you, from Prism, which is where we order our patients' dressings from, it is $27.
See what I'm saying? That's why we tell them to reuse it, because
Yeah.
people were using that and throwing them away.
Yeah. And then if you go, I think it's, 1 gram tube is $35 a tube. Parthenon that I told you about, some patients, they can get a box of 10 for $66. So that's the cheapest we have found it. Yeah. So it is expensive. We kind of talked about troubleshooting stomas, when to use skin prep. That's always a topic, and we're always educating not to use it unless you're crusting. So don't use skin prep. Even if you're using adhesive remover, make sure you're cleansing the skin with warm water afterwards because it still leaves a residue on there. I think that's it. The wrap I didn't mention when I did the wrap. Some patients complain it's too tight during the day. Well, I tell my patients, well, that's your clue. It's time to prop your leg up and elevate because you're starting to swell in that wrap. Some patients just can't tolerate it. I tell them you can cut 1 inch up at the top and then down at the feet, and sometimes that alleviates some of the discomfort. But I tell my patients with edema and compression elevate breakfast, lunch, and dinner. So they kind of, get it.
I think that's it.
Thank you.
Unless people have other questions.
Good job, thanks.
Thanks.